patients with neuroendocrine tumours should be discussed at a multidisciplinary team meeting for neuroendocrine tumours. So be that in St. Vincent's Hospital or be that here in Cork. But I think every case, every neuroendocrine case merits a multidisciplinary team discussion. So, that's on the simple side of things, an appendix that's removed by a surgeon in, let's say, Kerry General Hospital on a 25-year-old who happens to have a 2-centimetre neuroendocrine tumour of the appendix with involvement of the mesoappendix. So that should be discussed at a neuroendocrine. We should get a letter on that patient. We should review the pathology at our MDT meeting, and we should make a formal decision on that patient in terms of whether any further treatment is required, whether any further monitoring is required. So that's what I think should happen.
I agree with that. Can I just say that we had a patient recently who was sent from seen in another hospital in Dublin and had an appendiceal tumour. And this, for us, we looked at this. Justin was there as the lead surgeon, had the pathologist, and the patient clearly didn't need any further. Now, really didn't need any further treatment. However, this was completely at variance to a multidisciplinary group discussion among non-expert neuroendocrine tumour specialists. And the patient had been told that needed further surgery. And going back on that decision was extremely difficult because the patient had been worked up as to why, and had been convinced by the people in the other hospital that surgery was needed. And it was only just a simple appendicectomy at the outset. So there was a discordance with what we were saying. We have the data and the guidelines to back us up, but regardless of that, I don't still know whether the patient would want to have surgery or not. And it was a terrible dilemma. And I feel that that's terrible. I mean, the groups know that we exist, and they've got to, we saw the patient came to us, but even, despite everything, not seeing the right people at the outset was a problem for this patient. And that's what we have to get over. And I think you've helped enormously as a patient group with all of the discussion to various people, and that's what we're about. And the more we do that, the better. And I think there's nobody better in the room that can answer that question, both of those questions, than Professor Eriksson, because she's a great experience with that.
Yeah, I think, we have had, in Uppsala, we have been fortunate to have good colleagues in endocrine surgery. They're excellent, good radiologists, pathologists. We have Lars Grimelius, he is 85 years old, but he was the first pathologist to introduce a pathological staining. So we have, since I came into the field in the 80s, been discussing these patients in group. Of course, many patients are referred from other places. 90% come referred from other parts of Sweden, and there might have been some misdiagnosis or incorrect handling, but we try, when they come to us, to get on the right track. So I think that is very important to have all the specialties available when you discuss a new patient. That is a routine now in our hospital, but it's difficult to tell other hospitals or inform them. You have to, there's politics and other things, so.